We're going to talk about the matrix on functional anatomy, and we're going to talk about what we need to do to the front teeth, the central incisors, what decisions we need to make while we're fabricating new central incisors. Okay, I'm Nicholas Rallis. I'm associate faculty for the Dawson Academy, and I welcome you all. So I grew up in a little village in Greece. You can see my village on the screen there on the left. I always put that in my presentations. It keeps me humble. It reminds me where I grew up. And I say, God bless America, because only in America can you grow up in a small village and then get to teach for the prestigious Dawson Academy. So I thank you all for listening to me. This is a picture of myself, one of my mentors, Dr. John Cranen, and of course, Pete Dawson. My personal information is there, my email and my cell phone number. So in case any of you have any questions now, tomorrow, in the future, you can always reach out to me with any help that you may need. Dr. Lenny Hess, who is our current he is leading the Dawson Academy right now, and that's our space here in Bayside where we actually do some hands-on. We've done some hands-on work, and we also do part of the Dawson Academy New York City Study Club. I'm going to leave you with a couple of quotes. One is by Aristotle, and he was a pretty smart guy, and he said that the mark of an educated mind is to be able to entertain a thought without accepting it. So whatever I'm going to tell you today, think about it. You don't have to accept it, but at least think about it. And then another one of my favorite quotes is one by Einstein, another smart guy. If you can't explain it simply, you simply don't understand it well enough. So I'm going to make this presentation as simple as possible, so that way you know that at least I understand it. So I'm going to make it simple so that everybody can understand it as well. All right, so let's get started. So we're looking at central incisors, and we have a patient who walks into the office and his teeth look like all worn, and he says to you, I want to fix my smile. So where do you start? So we know that form follows function. Basically, function dictates form. So if we make the teeth functionally correct, then the teeth will be beautiful and they'll fit that patient. So how do we do this? Where do we put the incisor length? Do we increase it? How much do we increase it by? What about tooth proportion? Do we lengthen it? Do we go up? Do we go down? Do we do something with the gingiva? Who determines that? How do you determine that? What tools do you need to determine all that? And do you determine that, or do you allow your laboratory technician to determine that? So we're going to talk about how we determine the size and the proportion of the central incisors, and then how we communicate that with our lab tech. So we have 4 pathways to success, 4 pathways to get us predictably to where we want to go. The first thing is we have to examine records. So anytime we change somebody's aesthetics, anytime we change the way the teeth fit together, we must follow this protocol for success. Number 2 is we do a 2D and a 3D treatment plan to determine exactly what options we have. Then we take our determinants and we create provisional prototypes for these patients. And this is a test drive that the patients are going to test drive these prototypes before we can get patient approval, and then we can transition that to definitive restorations. So some of you may say, well, you know what? That sounds great, but I have a PPO practice and I accept all this insurance and I don't have time to do this. I have to see patients because I'm not really getting paid well from the insurance companies. So when you learn these protocols, you basically standardize your treatment. You work more predictably, you work more efficiently. You do the work correctly, so there's no do-overs, there's no broken provisionals, there's no emergencies between visits. You can actually maximize your per hour production. You can combine visits, and you can do more dentistry per visit, and that's how you increase your profits. Eventually, you gain confidence, and you can actually limit PPO participation. But you need to be able to do this, and you need to be able to deliver, and you need to be able to do something that everybody else who accepts PPO cannot do in order for you to be able to deliver this type of dentistry in a fee-for-service setting. So if you're participating with any insurances, I think this is a must. I think I would recommend that you look into this and you do this so that you can do less dentistry and be more profitable. So when we replaced the central incisor, I came up with a few things that we changed just by one tooth. We changed the aesthetics, the phonetics. We changed the anterior guidance. We changed the anterior context. We changed the envelope of function. We could impinge on the neutral zone. We could change the gingival architecture or the papillae, the embrasures, the midline, and then of course, the golden proportion that drives all of our anterior aesthetics. So when you look at these patients and they come in like these with all of their teeth worn, what are we going to do differently for these patients so that our porcelain restorations doesn't have the same fate as their enamel? Let's see here. So we're actually going to start our occlusion from the temporomandibular joint. So when we look at the joint, we look at a biconcave articular disc fully seating in between a convex condyle and a convex articular eminence. And that is important because where the jaw sits here really matters here. It really matters on the teeth. We cannot, it's not about taking stone models on a benchtop and figuring out which way they fit well, which way they fit against each other in the best MI occlusion. We have to take into consideration how the jaw is seating before we can do anything with the teeth. So we call this fully seated joint position centric relation, and it all starts from here. Every occlusal scheme should start with a fully seated joint. So it is the uppermost, most anterior, most comfortable bone braced position of the condyle in the glenoid fossa, and we call this home plate. This is where it all starts. There's nothing mystical about it. We need to have a fully seated joint before we start doing our treatment. So then what we look for is, once the joint is seated, then we want all of the teeth to touch at the same time with the same force when we bite together. Something has to keep the teeth from super erupting, the ones that are not hitting, and most likely some sort of a substitute, and in most cases that would be the tongue. So we want to make sure that the joint is seated fully, and we want to make sure that when we close, all the teeth are hitting at the same time, and nothing is in the way of that jaw seating at the condyle correctly. So what we don't want this. This is an animation by BiteFX that I use a few times a day. So we don't want the jaw to close together. We don't want the teeth to hit where we get a premature contact, and then the jaw has to slide for the teeth to close together. So we're actually looking at the teeth biting all together at the same time. And what we want to do is we want to create non-interfering posterior teeth. So all the joints in our body are made to work properly from a fully seated position. So when the movement starts, it has to start from a fully seated position. The same thing applies to the temporal mandibular joint. It must be fully seated when it starts working to allow proper movement. So the desired occlusal scheme that we're looking for, where back teeth don't rub, only happens from a fully seated joint position. So we're looking for dots in the back, and we're looking for lights in the front, and that happens only when the joint is seated and the teeth and the jaw starts to move from a fully seated joint position. So a key point here is that the biggest enemy of a stable occlusion, comfort, and maintainable oral health is when the back teeth rub. So when we create our occlusal scheme, we want to make sure that the back teeth don't rub. So the movement of the incisal edges of the lower incisors against the sigillums of the upper incisors create and determine the anterior guidance. The only job of the anterior guidance is to make sure that the back teeth don't rub. When the back teeth rub, we get muscles that are working in non-harmony. We get teeth that break. We get teeth that are unstable. All that because rubbing of the teeth is caused by non-fully seated joints. So we need to get it correct, and we cannot overlook the lower incisors when we are doing our occlusal scheme. So our goal is that when the jaws are in CR, so when the joint is seated fully, when the teeth bite, the teeth have to be in MI. We take a series of photos to determine our occlusal scheme and to determine our anterior aesthetics. And basically, we look at all of them, but when we look at the anterior teeth, shots 7 to 10 is really what we concentrate on. Another thing that I'm going to mention as an aside is actually the neutral zone. So when we're talking in football, the neutral zone in football is the width of the ball, and it cannot be impinged before the play starts. The same thing, so in dentistry, the neutral zone is the space that the teeth reside in, because we have the outward force of the tongue and the inward push of the lips and the muscles, and there is a balance, and with that balance comes a space where the teeth will actually reside. So if you can just see from this animation here, we have the teeth erupting, then we have forces outward from the tongue, inward from the lips, and we have to keep that balance in order for the teeth to become stable. So does the neutral zone affect our anterior restorations? It absolutely does. So there is really no occlusal scheme that can stabilize the teeth if they are in an unbalanced relationship with a muscle, if there's muscular forces against them, because when teeth and muscle war, muscle always wins. So a lot of instability that happens in the teeth happens because we impinge that neutral zone where the muscle forces are. So after centric relation has been verified, after we verified that our joint is seated fully, then the next thing we have to do is we have to look at the lower incisal edge position and contour. And those are the first decisions that we must make regarding the whole occlusal scheme. So the lower incisor edge position is oftentimes overlooked because when we restore anterior teeth, a lot of our patients say, I just want to fix the upper teeth because that's what shows. The lower teeth don't show, therefore, I don't want to concentrate on it. But unless we know exactly where the incisal edges of the lower anterior are, we can't really create our upper anterior teeth. So the lower incisal edge position is critical to aesthetics, phonetics, the occlusal plane, the function of the anterior teeth, and it's definitely critical to stability, and we're going to go over each one of those. When we look at the lower incisal edge position, it definitely has a flat facial thirds. It definitely has a wide incisal, and it has the incisal angle is very, very prominent, and that's what we call the leading edge. And that is the driver in anterior guidance. So the lower incisals are critical to aesthetics in the Vig and Brunto study that we use when we do our aesthetic determinants. In a 30-year-old, when we speak, we show a 0.5 millimeter of lower incisal edge. When we go down, when we get older to 70 years old, then we show up to 3 millimeters of incisal edge on the lower teeth. So that's why they are very, very critical to aesthetics, because they do show when we speak. It's the speaking position of the teeth. So during speaking, the incisal half is visible, and the correct positioning of the lingual of the upper anteriors is actually dependent on the position of the lower incisor plane. It's critical to phonetics because we have to approximate the lower incisal edges with the cingulums of the upper teeth when we make the S sound. So there is a special relationship between the lower incisal edge position and the opposing surfaces of the cingulums of the upper teeth for us to make the proper S sound. It's critical to the lower incisal edge position, and it's critical to the occlusal plane. We know that the curve of Spee and the curve of Wilson, and they start from the curve of Spee actually starts from the incisal edge of the lower anterior teeth. And what we want to see is we want to see the whole lower incisor scheme be in a convex rather than a concave position to be able to approximate against cingulums of the upper teeth. So the lower incisors are very much critical to stability. So when we have the two fully seated joints that are actually bone braced, there is a definite stop there. And then when the lower incisors are occluding against the cingulums of the upper teeth, then you get a tripod, which is an inverted tripod, which is actually very, very stable. So the joint movement must happen from a fully seated position. And once you have this tripod, then basically you can literally throw the back teeth in there, get them to occlude properly, and then in maximum incaspation, and then basically all you have to work is you have to work out the guidance to make sure that the posterior teeth don't rub. So an inverted tripod is very stable, and that's why the incisors are very critical to stability. So having said all that, we're going to now start talking about the matrix of functional anatomy. So now that we understand the role that the joints play and the role that the lower incisors play in our occlusal scheme, we're going to talk about 6 decisions that we have to make about the contour, the inclination, the position of the central incisors that determine the correct functional and aesthetic position in the mouth. So the first one we just spoke about, actually, it is the occlusion of the lower incisal edges against the upper cingulum. There is a definite stop that has to happen there. So when we customize the anterior guidance, what we're actually doing is we're designing a place that we can locate the correct position of the incisal edges. And then when we look at anterior guidance, we're looking at the ideal overbite and overjet of the central incisors, 4 millimeters of ideal overbite, 2 millimeters of ideal overjet. And then on the canines, we have 5 millimeters ideally of overbite and then 1 millimeter of overjet. So looking at the second determinant in our functional matrix, it is the labial surface of the upper half of the central incisor. And what we want to see there is the gingival half plane for proper lip rest has to follow the contour of the alveolar process. And that is actually captured, and that needs to be captured actually in the scan or in the impression. And the facial preparation actually is a 2-plane preparation. And the third determinant, okay, which is actually the labial surface, which is the incisal half, is again 2-plane. We determine that from our matrix, from our wax up. So once we get our wax up, we have our guides, our prep guides, and we want to make sure that we use the prep guides to give the laboratory enough room so that we can make the correct amount of porcelain and we can have the correct contour of those teeth. So the facial plane must be in harmony with a lip closure path, and that's the reason why we need 2-plane preparation. If the porcelain is too bulky, the patients will often complain that their lips bump on the teeth. Now, the only way that we can determine this is actually in the provisionals. We can determine this in the mouth. So when the lower lip closes, it has to come past the incisal edge and it has to close in a very, very smooth closure path. Number 4, we talk about, now we are trying to figure out where the incisal edge, the actual incisal edge is, or the length of the incisal edge. So we evaluate the length of the incisal edge using the smile line, the rest position, and the E position photos from the set that we take. So take a look at these photos. You're going to see that on the upper teeth, I don't know if you guys can see my monitor, but here I had to lengthen the incisal edges of these teeth because the wax up was very short. So what we're looking at the wet dry line from a 30-degree view from behind the patient, and we're trying to make sure that we keep those incisal edges inside of the wet dry line. Then we're also looking at the rest position, and we're looking at the E position, and that's how we evaluate where the incisal edge is. The most important thing, though, is that we evaluate the incisal edge using the F and the V sounds. Now, when we're looking at the E position, we're taking a measurement of the borders of the upper and the lower lip, and then studies have shown that all the patients, we can bring the length of the incisors to the 50% mark, and the younger patients up to the 70% mark. So looking at this here, you can see that when we take this distance, the 50% mark is right about here, and you can see how short this patient's teeth were. So that's the reason why we had to lengthen those. But this is a very good determinant of how we figure out the incisal edge. So when we look at the inclination of the incisal edge, the horizontal position actually precedes the determination of the length. It precedes the vertical position. So we have to figure out the horizontal first, and then we have to figure out the vertical. When we're looking at the F and the V sounds, if the patient closes, if they say the F and the V, and a lot of times what may happen is they may be hitting the incisal edge, and the patient will actually say that it feels kind of heavy, then we can go ahead and reduce it. And we do all that in our provisionals. So now we have to figure out the anterior guidance. When we look at the anterior guidance, we're looking at smooth. We're looking at a smooth protrusive path from the contact all the way to the incisal edge, and we want the anterior guidance to be in harmony with the envelope of function. We're looking for smooth lateral excursions, and we're also looking for the anterior guidance to be correct both inside out and outside in. The other thing we're also looking at is we're looking at the leading edge of the lower incisors, the lower anterior teeth. And again, remember we said that the leading edge is a definite incisal labial line angle. So to have this, it is the most natural looking, most stable, and again, it must form a definite stop on the cingulum to prevent super eruption of the tooth. When we're looking at long centric, and long centric is something that's very misunderstood. We generally do all of our occlusal scheme with a patient sitting back. So when we're looking at lung-centric, we have to sit the patient up in a very relaxed position, and we have to have them bite. What happens when the patient sits up? Sometimes you get a little bit of anterior posturing of the mandible, and we end up hitting prematurely into that cingulum area. So what we want to do is we want to let the patient tap gently, and we have two markers, a red and a blue, or a red and a black. We have the patient bite when they're laying back on the black paper or the red, and then we seat them up and we have them bite on the other color paper, and we see if they coincide or if one of them is anterior to the other. The one that is anterior, we take that off until we create a very smooth path. Now, what we don't want to do is we don't want to adjust the lower leading edge of the lower tooth. That is the driver in anterior guidance. We always want to make sure that we touch or that we relieve the incise, the cingulum of the upper tooth. So again, we spoke about this before. We want lines in the back, and we want, we want dots in the back and lines in the front when we're talking about anterior guidance. So anterior guidance, basically looking at this animation again, we're looking at very smooth, a very smooth path, and then the anterior guidance, we want, we have it so that we can prevent the back teeth from rubbing. Remember, the biggest enemy of stable occlusion and comfort is back teeth that rub. We want the anterior guidance to be steeper than the posterior morphology, and that's how we exclude the posterior teeth. And the job too of anterior guidance is to be in harmony with the envelope of function. Then we evaluate. So the anterior guidance must be stiff enough to exclude the back teeth and concave enough to be in harmony with the envelope of function. We just went over that. Then we have to evaluate the S sounds. Now, if there's too much space in between the incisal edges of the lower teeth and the cingulums, we're going to get the S sound is going to be exaggerating, or the patient is going to be lisping. So we want to make sure that we can add to the cingulum of the upper tooth if need, to create a very, very smooth and a very very gentle spoken S. And that is actually always worked out in provisionals. So the last thing we're going to talk about is we're going to figure out number 6, and that's the cingulum contour. And that is the position right next to the gingiva. And we always evaluate that using the T and the D sounds. So again, we've gone through our complete examination. We did our 2D and 3D treatment plan. We've done our provisional prototypes in plastic. And now we're ready to go from our provisional prototypes to definitive restorations. So how do you communicate that with your ceramist? Okay, so everything has to be worked out in the provisionals, like we said. The provisionals is a test drive for the final restorations. So we have to make sure that we tell our patients that they must do everything with the provisionals that they would do with their final restorations. They have to eat, they have to chew, they have to make sure that they don't baby them. If anything breaks, we want to make sure that they break in the provisionals so that we can go ahead and figure out what the issue is and correct it before we go ahead and do our permanent restorations. So once the patient has approved the provisionals, Then we take a Facebook record, we take photos, we take scans or impressions if you happen to be taking impressions of all provisionals. Facebook and photos are very, very, very key because that's what your laboratory technician is going to use to fabricate the final restorations. We want to make sure that we give them a prep shade. If you're doing aesthetic work where you're doing either feldspathic or whether you're doing anything other than zirconia, you're going to need to give them a prep shade. So then the ceramist will replicate the patient-approved provisionals in the porcelain. Once the provisionals, once the permanent teeth, the porcelain restorations are put in the patient's mouth, there's no surprises because they are an exact replica of what the provisionals were. We're going to go over a case right now. A case that I did a few years ago that uses all these principles that we spoke about. So we have our photos, the series that we take from the academy series that I call them. Breast position, E position, tip down smile. That's the 30-degree smile that I call. And then we have side views. And all of these photos are actually meant to give us diagnostic aids. And when you come to the academy and do the courses, we're going to teach you exactly what each one of these photos mean. We're looking at the gingival contour. We want to make sure that everything is in harmony. In this patient here, you see that tooth number 9 and 10 and 11 were the gingiva was higher than 7 and 8, so we needed to do something there. We're looking at the E position, and the teeth were definitely short. Golden proportion is something that we use with every single patient, and we want to make sure that the teeth are in harmony with the golden proportion, that all the teeth, the shape and the size of the teeth are in harmony with each other and with the patient. So in this case, we have a 9 millimeter wide central incisor, and then we need to figure out what do we need to make, what do we need to do to that tooth or to the set of teeth to make the teeth in harmony with a golden proportion and with the tooth itself. So we're looking for an 80% length to width ratio. So in this case, we had to extend the teeth incisally, but we also had to do some gingival recontouring to extend the teeth gingivally. Again, these are models of our wax-ups. The preparations. Now, when I do these cases, because I can get that tripod effect very easily, I generally do them in 2 visits. I prep the whole case in 1 visit. I take all my scans, my prep shades, my photos, and I make the provisionals. I take actually my scans in this phase, and then I have the patient come back 3 or 4 days later. We work on the provisionals, and if they're happy, we take photos of the provisionals. We take scans of the provisionals, just like I said, and then we send them to the laboratory to get us the final restorations. So all of this is done generally in 2 main visits and an auxiliary visit in between for photos and for scans of the provisionals. These are our provisionals. We make sure that the provisionals are a replica of what we want our finals to be. So, so when you take a look at his mouth right now, you see how easily it is for him to smile, and you see how his teeth, he's very relaxed because the teeth fit correctly in the mouth. We take a look at the before and the after. In the rest, you can see how the incisal edges of those teeth were not visible during the pre-op, but yet visible during the provisional phase. So when he's smiling in these photos here, you can see on the upper one, he has to strain his lips to smile to show his teeth, and you can see how much more natural they are on the bottom. So we're going to go into our definitive restorations now. So this original work was done in 2017. You see here, he's missing the first molars. So in 2022, 5 years later, we ended up doing the restorations on those implants. And here are the photos from 2022. So 5 years later, it's been almost 7 years now. This was done in January of 2017. So it's been 7 years now, and his teeth look exactly the same that they did when we did them. He takes very, very good care of them. The occlusion was correct, and aesthetically, patient was very happy. So this is the before and the after. The ceramics were done by Shoji Suruka from Bayview Dental Lab, and we're very proud of the work that we put out for our patients. And thank you to Shoji for helping us. So I'm going to leave you with a couple of things. I'm actually done with the presentation. I'm going to leave you with a couple of things. One of my very best quotes that I love is this one here. No one can go back and start a new beginning, but anyone can start today and make a new ending. So think about that one. And then I'm going to leave you with this slide that you can actually scan to request more info from the academy. It's core 1, occlusion and smile design, and the next one is going to be in Nashville, May 17 and 18. It's a great time to be in Nashville. So I'm going to leave it up for a second. You guys can go ahead and scan that. And with that, I'm going to thank you all. And I'm going to thank my teachers, my mentors, my students, my colleagues, and our team at the Center for Smiles for their support in helping me honor Dr. Pete Dawson's legacy. God bless you all. Thank you.